Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. Happy New Year. My name is Terry Fletcher. Hope everyone had a good New Year, ready to get started in 2025. And with that, I'm going to talk about something that I think I've kind of mentioned before, but it comes up every once in a while, and I'm in the middle of a very big audit right now. And a lot of the primary care encounters include annual well visits with 25 modifiers with E&M services. And we want to make sure that you are doing things correctly as the new year starts, because I know there's a lot of confusion sometimes in what you can code, what you can't. I see annual well visits coded, and then on top of that, I see providers trying to charge for a depression screening, which is included in either an IPPE or the annual well visit, or they're also trying to charge for advanced care planning, which again is included in annual well visits and IPPE. So trying to carve out those services that are included in the annual well visit, it's really not going to help you, because eventually you'll have to pay money back. And some of those services may have a copay. And not the G codes, because those are without share of cost for the patient. But when you code an annual well visit, an AWV, there are certain concepts that you still have to follow, especially when using the 25 modifier. So remember, the annual well does not include managing refilling medications and managing conditions. But if you're just refilling a medication and you're not addressing a condition, then there's no significant separate service to be able to code something different as an E&M service with an annual well visit. And so there are several places you can find the information on this. And one is cms.gov/outreach and education. And you want to look for the MLN that talks about annual well visit. You can also Google it. But when you provide an annual well visit and a significant separately identifiable medical evaluation, so it has to be medically necessary, but a medically necessary E&M service, it says they will pay for an additional service, and you would report the E&M services with the 25 modifier. But medically necessary and reasonable to treat the patient's illness or injury to improve the functioning and malformed body part. They're saying that it has to be above and beyond what's on that checklist for an annual well visit, and they have one. All you need to do is go to 42 CFR 410.15A, Roman numeral 8, VIII, and B, and then they give a list of certain risk factors, tertiary interventions, and things that are recommended that talk about risk factor reduction, including mental health concerns that you're talking to the patient about. You're walking them through it. And that's also part of the initial preventative physical exam, which is the IPP I mentioned. So it's really tough sometimes to know where that gray area is. And if you are, again, just saying, okay, and we'll continue to refill medications, because a lot of times patients refill at their preventative service without any kind of management or discussion or anything, just saying refills for next, 90 days. If you add calcium or vitamins or, vitamin D or something like that, supplements, that again is part of the preventative service. And even in E&M, it talks about using that modifier 25, which again is always on the OIG watch list, always on the work plan. And so when you have show that it is a significant separate service, one of the big things people miss is above and beyond the other service. And a lot of times it's not above and beyond that satisfies the criteria. I mentioned I'm in the middle of an audit right now, which I'm kind of just depressed about. I'm a little sad about, because right now I've got an 80% error rate for things that are trying to be billed, separately when they're not supported within the note. And I'm hoping for some light here, but it's tough. But when you're billing for annual well visits, those support the patient's current condition, medication, and that is a required component of the annual well visit. You need to just still, maintain a list of that, understand, what the patient is going through without saying that there's something else wrong. If the conditions are stable, the provider would need to establish, again, medical necessity above and beyond the annual well, to try to say that this is an E&M problem addressed, or this is something else above and beyond just refilling medications alone, because that does not support a medically necessary visit unless you have to change something because of a problem addressed, or the dosage is wrong because maybe of an adverse effect or something's not working. So before you add that 25 modifier to any claim, ensure the definition of the modifier is supported in the documentation, and more times, it's just not. And for those of you that know me, I do audits not just for private practices, but also for payers. And I'm seeing it on both ends, which is really unfortunate because I am a physician advocate. I want you to I want you to pass your audits, but when I see this blatant abuse of overcoding and not supportive, and I saw a record today that basically said that the patient came in for discussion on their food menu. Now, here's something interesting. All the documentation said it was a lifestyle medicine, which is a cash pay. It doesn't even qualify for any preventative. They were just talking about portion control and what the patient had to do. There was no issue with obesity. There was nothing they were talking about there. It wasn't even medical nutritional therapy. It was just a PA talking to a patient about how to grocery shop. And then I saw at the end, it said they added diabetes for HCC, but there was no diabetic management. There was nothing that tied that to the conversation. It was not about talking about that chronic condition. It was just talking about how to make better food choices. That was it. And there was no E&M that should have been billed when they tried to bill a level 4 visit. And I was like, you've got to be kidding me. And, they got triggered an audit from one of the commercial plans, a big one. And I tended to agree with a lot of the commercial plans comments because there just wasn't that moderate level. There wasn't even low level options there. So you have to be really careful when you bring a patient in for just, hey, how you doing? Yeah, let's talk about how much broccoli you should eat today. That's not okay as far as trying to bill a problem-oriented visit. And there are rules when it comes to medical nutritional therapy by, let's say, registered dietitians or even a trained mid-level provider. It has to be related to a patient who's got, type 1 diabetes, even type 2 just controlled with medicine. If it's not necessary to also have to control, dietary issues to the extent that it warrants a visit because things are out of control, then it's not an E&M. And so that's a real problem that I'm seeing right now is medical necessity within the record, not just meeting the points that you have to meet and the elements, I should say, for the E&M, but the medical necessity is just not there. And you don't want to get tagged in 2025, especially with the new administration coming in, new HHS secretary, new Medicare administrator, new everything, because you just know, and there's going to be new people at the top too, at the OIG and the DOJ, that may or may not be more litigious, may or may not be more committed to detail and not free for all like we've had. And when they see, how much money has been returned, especially on the watch with Medicare Advantage programs, and there's also one of the things at the companies that I'm looking at, and I'm in their EMR, certain EMR companies encourage providers to add diagnoses that are not active so that they can get that HCC boost, and that's not okay. If it's not active, it's not something today that you're dealing with, and it's not an active diagnosis, then it shouldn't be added to that list today, and it can really trigger a false claim act and a false claim situation. So we don't want to do that. So as we get into the new year and just really look at making sure that we are compliant, that we are doing things correctly, that we're not pushing the envelope too far, this is the first place I would start. Making sure that things are medically necessary, make sure you have that conversation with your providers, and do things correctly, best practices. I also want to remind everybody, and you're probably sick of hearing me say this, But telehealth, and I'm getting these questions on and on and on. First of all, if you haven't made that decision or that leap to join our membership for the Coding Corner, where you can get unlimited questions and answers through email, please look at my website at terryfletcher.net. Look at services. The first drop down is what is included in that. We have two different types of membership. We have regular membership, and then we have executive, which includes an Ask Me Anything Zoom call quarterly. But one thing, and also you get newsletters with both, but one thing that I think has been becoming a problem is really understanding the audio only situation for 2025. So we did get a blanket extension for telehealth audio and video. So it means you can use the office visits with place of service 10 if the patient's in their home, if they're in the hospital or whatever, it'd be 02. But just remember that for audio only, we don't have a code anymore unless it's behavioral health, substance abuse disorder, or end-stage renal disease. And what that means is that if the patient is unable or does not want to use the audio and video, then the office visit would be appropriate with either the FR modifier, which means behavioral health, audio and video with physician present, or the 93 modifier, which is audio only. But remember, this is not for any other diagnosis. So if you're a cardiology practice or family practice or anything, you cannot use office visits unless you have behavioral health, SUD, or end-stage renal disease. So be very cognitive of that, because I'm seeing that there's some different publications out there, which I will not name, but just be aware that they've said you can use it for anything if the patient says, I don't want it. You can't. The final rule, look it up, page 140 to 141, it specifically states that you cannot do that. And so this will be through March 31st, 2025. The audio and video, yes, that was extended, and they're not recognizing our new CPT telehealth codes. So we have to go back to our regular office visits, which is stupid to me. But yeah, that's my professional opinion. It's just stupid. But hopefully the new incoming HHS Secretary, RFK Jr., he will make a change there and open that up for payment, because you're supposed to report codes that are specific. It even says in CPT page 1, do not approximate a code the actual code. So the fact that there are codes that exist, maybe in the future, after, starting in April, they will do that. Now the 98016 code, that is for the virtual check-in for established patients. That changed the G2012. That just is now, instead of that, that's not really considered telehealth. It's just a virtual check-in in case the patient, they might have to come in, but this is to avoid coming in. If they end up coming in, then it's a moot point. You don't use that code. So that's something that you want to take a look at as well. But I'm always being asked telehealth. That's the only thing I seem to be asked lately. So also, if you need a webinar that you haven't been able to take, any of mine that I've actually done recently, in December I had 3, then make sure you order my on-demand. You can also get that on my website under webinars, because we have the one for 2025 that discusses all of this, gives you cited references and everything. So hopefully you'll find that helpful. All right, everyone, again, Happy New Year, and I really hope that going into 2025, you're excited for what's to come. You're ready to start again with the new. You've got your year-end done for last year, and we hope to see you, not just as a membership client, but also continuing to have you as listeners on the Codecast podcast. We are up to over 1 million, I think 1,100,000 listeners in our 7 years around. So we're really proud of that. And we will continue to give you hopefully good information and accurate information and updated information as we continue the journey. All right. Make it a great day. Make it a great week. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.